This is a webinar. We're sponsored by the American Functional Medicine Association, but what we want to talk about today is progesterone pellets. And let me go back one. What, when, and how. And I'm sure a lot of you guys have heard about pellets. I've heard about pellets for a long time. I personally have not been a big proponent of pellets because they didn't have progesterone pellets. I felt a little uneasy putting estrogen in patients and then hoping that they were going to take their progesterone. So I didn't really see how it was helping with compliance when I'm putting in estrogen, but still you got to take a pill every day and still you have to put cream on every day. And then I think that people, because there weren't progesterone pellets readily available, they started to try and make testosterone fill the gap. So they were trying to convince everyone, all these women, I know men may need testosterone, all these women that they needed estrogen and testosterone. And Dr. Starr, I mean, as OBGYN, I just know that testosterone is not a major hormone in women. It's not. It's there. If you look at Spiroff, it says, you can have a person who's hirsute and she can have a normal serum testosterone level. So I just wasn't convinced that I should put estrogen and testosterone in all of these women. So I avoided it. So when I found out there were progesterone pellets available, that made me start to think, well, maybe I can start using pellets now, because it is, the less you have to depend on a patient to do something, the more likely they are to do it. So if they only have to do something 3 or 4 times a year, it's more likely they're going to do it instead of doing something every day. So I considered pellets, but I want to show you a case that convinced me that I should stand up and say something. Okay, so this a person came to me and asked me if I would oversee their clinic, and they had someone who was working there. They were thinking about having me come in, and so the first patient I saw was this person. This is I think this is like a 47, 48-year-old female. And her testosterone, serum testosterone was 24.5. Can y'all see that? Mm-hmm. Okay, 24.5, normal is 20 to 80, and the goal is 100 to 200. Now, I don't understand where you get those goals from. I really don't. Because one, if you're giving a hormone that's coming from somewhere other than the gonad, then you're not necessarily going to see the full picture in the blood. And nowhere in Spiroff or any other book does it say that a woman's testosterone should be 100 to 200. It's just, and I don't believe that we should be given super physiologic doses of hormones. It taxes the detoxification system. It downregulates the receptors. So I just don't understand it. Okay, so that was initially. So then they gave her 62 milligrams of testosterone. Her testosterone went to 134. So then her hematocrit goes up to 51. And, it's very hard for a woman, if they're not smoking, to get their hematocrit up that high. And then they have these goals for progesterone and FSH going down to less than 10. Now, I know there's a company out there that's very popular that's talking about estrogen and testosterone pellets in people. And the way they say to monitor it is by lowering the FSH. FSH is associated with inhibin, not estradiol. And you have to get the estradiol up very high to a superphysiologic dose in order to get FSH down. So if your goal is to do that, you're going to probably overdose the person with estrogen. So I could not follow that thought process. So anyway, so let's keep going. So I'm going backwards. All right. So now this is when I saw her. This is in October, and the first one was in June. They treated her in August, and now she's coming back, and she has her pellets with her, and she wants me to insert her pellets. Now her testosterone is 107, but then I noticed that on her intake sheet, she says she's having increased hair growth and increased genital size. And I walk in there and she said, Dr. Taylor, Do you think that I should get these pellets put into me? Because I thought I was going to grow a penis and it just went down a week or two ago. So, of course, I did not put those pellets in. And this is just, I mean, I have a real problem with giving people super physiologic doses and saying that we should wait for them to have a symptom. And the symptom is hair growth and genital size. She never should have gotten a a, a blood level up that high. There's nowhere in the literature that you should have a person's testosterone that high. Now, I know that Dr. Glasser has talked a lot about testosterone and prevention of breast cancer, and I'm not arguing about that, but here's the problem. That may be great for breast cancer. It may be great for breast cancer survivors, but to do it on a general scale, you're going to end up with problems. Now, am I saying that everybody who has 107 is going to have, increase in genital size? No, but I'm saying there's better ways to monitor it. I wouldn't ever try and get a super physiologic level like that. And testosterone is not the major hormone in women. She came in because she wanted to lose weight and she wanted increased energy. And she wanted her brain to work better. And you can see that she still has anxiety, she has some depression, and her memory and focus is still off. I talked to her. She has constipation, so I told her, some of this may be that she needs probiotics. And if you're only trying to fix someone by changing doses of pellets and only focused on hormones, you're going to come into a problem. So this is what got me started on this. Okay, I was like, man, this is getting to be a problem. So then I started using some progesterone. Let me see what my next one is. So this is a patient who I want to show you, is because she was having trouble. You see how her estradiol is all over the place? She was having problems with some hot flashes. We were trying to use patches that didn't really work. And so with this person, I used estradiol pellets. And it evened out how much estrogen she made, and she felt much better. And she was coming in for her next pellets. And the next time I gave her more progesterone. And I'll tell you about how I dose it. But I do think pellets are a good method. You don't have to worry about patient compliance. If you do it right, you don't have to worry about overdosing if you monitor them. And of course, this is saliva. These are saliva levels. And there are articles, and these articles are way back. Let me see what this is. This is like in the 1940s or 50s. And so this has been around for a long time, these progesterone pellets. And so there is literature out there about it. So I started using progesterone pellets, and I want to show you this. Let me see.
Well, yeah. I came to Atlanta.
Okay, great.
Last year from a hospital. It was my 4th hospitalization. I struggle with major mental illness, depression, suicidal thoughts, and attempts. And when I got pregnant, all of that literally went away. I had no symptoms of depression. I had no symptoms of BPD. I was tested and they said I don't have depression. And my mom looked into it and found out that progesterone can act as a mood stabilizer. She found out about Dr. Taylor and we contacted him. After I had my baby and started taking progesterone in the midst of postpartum depression, it literally went away. When I started taking progesterone, I felt like a normal person. I felt like I didn't even have mental illness, and I felt like I was actually functioning without the help of 50 different antipsychotics. And it's literally saved my life, and it's stopped anxiety attacks mid-anxiety attack. Like it's like a miracle drug.
So how are you taking the progesterone now?
Now I get pellets inserted. I was on the pills, but I personally think the pellets are easier. You don't have to remember to take them. And for somebody who's been on pills their whole life, it really makes you feel like a normal person. You don't feel like you have to swallow a bunch of pills every day to live. You wake up and you're okay. And it's one of the best feelings ever, honestly.
Yeah. And especially and Ms. Cox, I'm not saying anything derogatory, but younger people, it's harder for them to get them to do something every day. It's harder for older people to get them to do something every day. Also, you're using some of.
All right. So that was when I really got on board with this, because this girl, she had quit school. She had, let me see if I can get out of this. So you guys were able to hear that, correct?
Yeah.
Yeah.
Okay. So she wasn't able, let me turn this down, the volume down. She wasn't able to attend school. She's back in school now. I had to really up the dose on her, but we got her to a dose where she's doing great. Do the saliva testing is not, she's not overdosed at all. And this is one problem I have with the way some people are doing this. If you look at a blood test for if you look at a blood test for any woman, they are not going to have testosterone levels of 150 to 250, okay? They're not, because that's not normal, okay? So then the blood test is going to tell you that everybody needs the testosterone. Can you guys, am I sharing let me make sure I'm sharing the right thing. Okay. So if normal is 20 to 80, then no one is going to not need testosterone if you base that the range should be in over 100. So it's going to look like everybody needs testosterone, and it's going to look like everybody needs estrogen. But after you start it, the people who are talking about this the most, it says it is of primary importance to titrate the dose to achieve symptom relief and minimize side effects, not to achieve some phantom blood level. So here's my problem. Why do you use the blood level to initiate the treatment, but you discourage people from using the blood level to monitor the treatment? So I even asked one of the reps that. I'm like, why do you even use the blood at all if you're going to start everybody on it, and then you're just going to use the symptoms to decide how to dose it? So you can't say that it's telling you that the person needs the hormone, but then after that, you shouldn't try and follow it with the blood. Maybe I don't understand it. If somebody else can explain that to me, I'll be happy to listen. But I use salivary to tell me who needs it, and I use salivary testing to tell me how to dose it. I use salivary testing to tell me how to, and again, I don't have a salivary lab. I have no interest in a salivary lab, but you know, right is right and wrong is wrong. And no matter how strong your marketing is and how much money you're putting in marketing, it's still just not, it's not right. So again, if somebody wants to explain that to me, I'm happy to listen. I don't believe I know everything, but you know, when I see people come in and they're saying that they thought they were growing a penis, then something about your monitoring wasn't correct. And something about your desired levels was not correct. And so anyway, so hey, that's my thing. Now, how many people are doing pellets? Let me see, I'm trying to see if I can control. Who's not? Let's see. So, Dr. Starr and Dr. Zimmer, are you guys using pellets?
No.
I was going to do it, and I decided against it. I'm currently not doing pellets.
Why did you decide against it?
Because because I think it's important to make sure the patient gets progesterone, and I don't feel responsible giving them testosterone and estrogen if they're not really going to take the progesterone. Because what's the benefit? The benefit is carefree, right?
Yeah.
So if it's not carefree.
Yeah. So that was my exact same reservation.
Yeah.
That was the exact same reservation I had. They still have to remember to do something. So they might as well just, make sure they're doing it all instead of, because if they forget something, if that estrogen goes unopposed, then it's on me. I'm giving her unopposed estrogen, and somebody's going to say, well, hey, well, you made her not responsible for the estrogen, but you made her responsible for the progesterone. So that has been my hesitation also. And so now with this, and now I can do it like I usually do it. If I do a saliva test and their estrogen is okay, I just put in the progesterone pellet, like with this young girl. I didn't put in estrogen, progesterone, and testosterone. I just put in progesterone. That's all she needed. Now, you can't tell me that if I had to put in estrogen and testosterone in this young girl, that her symptoms would have been relieved like like you just heard. So for her, that was the only thing that was going to help, because the key, when she told me that pregnancy took away all of her mental problems, we had to do something to try and recreate pregnancy. And I tried it with pills. It worked pretty well. Now, the usual dose I use is between 100 and 300. She gets 300 milligrams. So that's kind of high, but that's how much I needed for it to last 3 to 4 months. I put in 200 before, and it wore out after about 2 months. So, but if you put in the right dose, and you I always err on the side of putting in too little, and a lot of times what I will do, is start them with a pill or a cream to see if it's going to work, and then put in the pellet. So I can know that, hey, if I get 50% of my symptoms relieved with the pills or the creams, then I may put in the pellet. Also, if it's cost effective. If somehow they're getting their pills, from a mail order, and it costs some source for you, because I charge $250 for a pellet if I'm using one hormone, and for each additional hormone, it's another $50. The kit that I use costs like $20, and the progesterone pellets are $50 per 50 $14 per 50 milligrams. So if I have to put in 200 milligrams, that's $56. So it is an income source for you. Now, I will tell you, there are people who are doing this in packages. The company that I showed you who mismanaged that lady with the testosterone, they were charging $3,000 a year to put in pellets 4 times a year and to give them a B12 shot. I think that was a little excessive for something that doesn't cost that much. Hey, but if you can do it, if your market will bear it, that's great. We're thinking about offering some packages where that's a part of a total health, where we look at their HRV and EIA. If you're going to give them the value of a couple of $1,000s a year, where you're going to really take care of them and not only look at their hormones and others, then I think it's it may be a fair price. But it is an income source. Patients are wanting it. They do want the convenience of it. It does work well. Now that they have progesterone pellets, I can use that just like I normally use progesterone. If you're going to, and I think a lot of times what was happening is that because you didn't have progesterone, they kept pumping up the testosterone and the estrogen, trying to get the benefits of progesterone. And so you end up overdosing them on a hormone that they don't need because you weren't able to give them what they really needed. And I've seen, a lot, I won't say a lot of patients, but I've seen several patients who have kind of been disenchanted by this estrogen and testosterone, because they were told it was going to make them lose weight and they were going to have more energy and it was going to make them want to have sex 3 times a day. And it doesn't, a lot of times, most of the time, it doesn't live up to the billing. Testosterone in men, no doubt about it, it has its place. I'm not arguing that fact. It still needs to be monitored appropriately. If you are doing it to the point where their hematocrit is going up, you're giving them too much. But, testosterone in women has never actually been a major, played a major role. I do use testosterone, but I use much lower doses. But I use testosterone mostly to help women maintain muscle mass. if I do a bioimpedance analysis and muscle mass is down, that's my number one indication for testosterone, because even the salivary testing can underestimate a woman's testosterone level. Even when I do it in saliva, most of the time it's low, but I really don't push testosterone unless muscle mass is an issue. So
Can I ask a couple of questions?
yeah, sure.
With regard to dosing, so setting aside for the moment younger patients and going to the menopausal patients, is there? I understand that you tend to use saliva testing. I don't. I actually use serum, blood testing. Do you have any sense of what kind of serum levels people are getting with progesterone pellets? Or actually, if not that, then as an OB-GYN, how I'm just surprised to hear that you can get away with 100 to 300 milligrams, given that, orally, a woman might have to take a milligram to maximum 2 milligrams of estradiol a day, and that translates in a pellet to somewhere between 25, 30 milligrams for 3-4 months. But progesterone orally, they have to take 100 to 200 a day. So I'm amazed that and I'm happily amazed that you can get away with, the same dose essentially as one night, of prometrium they can do as a pellet for 3 months.
Yeah.
So what's going on with their endometrium on those doses?
What's going on with their endometrium in a postmenopausal woman?
Yeah, it's fine. I mean,
Nothing, because see, I'm not giving them extra estrogen most of the time. See, I'm
even
just
postmenopausal.
Yes. See, you've got to hear my whole philosophy. See,
no, I mean, I was here from the beginning, but
no. Well, I'm talking my whole philosophy is that. Let me ask you this: your belief is that every postmenopausal woman needs estrogen?
Firm. My firm belief.
Yeah. Well, I agree that every postmenopausal woman needs estrogen, but a lot of postmenopausal women are making their own estrogen by aromatizing in their fat tissue.
Yeah.
Some, but they're not getting above a level of 50, which is the serum level that's been shown to prevent osteoporosis and lower the risk of heart disease.
Yeah. Well, see, here's what I would tell you is that if you, again, this is a whole day lecture. Okay, this is a whole day lecture. And I can show you in physiology books, if you are getting their serum, okay, then their tissue level is already saturated. Again, this is a whole nother discussion. But I agree that women need estrogen, okay? But the majority of postmenopausal women are aromatizing a lot of estrogen on their own that you will never see in their blood. If you look in their saliva, you will see it, okay? You will see how much they're aromatizing, all right? And if you're talking about preventing osteoporosis, there are so many more things other than estrogen that will prevent osteoporosis. Okay, so serum level of 50 may be one, but there's a lot of other things that can do it. Okay, so I don't agree that I need to get that serum level up to that level to do that. Weight-bearing exercise will do much more prevention of osteoporosis than estrogen ever will. And you're worried about their endometrium. Yeah, you're going to have to use a higher dose. If you're going to give them extra estrogen, you have to give them extra progesterone. No doubt about it. But if you look in saliva, if you look at how much a woman is aromatizing estrogen, then all you have to do is match that with progesterone, and you've solved the problem. Okay, so this is what I would ask you. Why don't people in other countries who don't take estrogen, why don't they get heart disease and their serum level is not greater than 50?
They do. I mean, I'm happy to.
Heart disease is an American.
There's so many studies. The best study that I've seen on hormone replacement therapy is the COP-D study, the Danish study that came out in 2012, where they gave 500 women bioidentical oral estradiol, 2 milligrams a day. And if they had a uterus, for 10 days a month, they gave them northisterone. I would have used progesterone, but they used northisterone 10 days a month. And they followed them for a decade. And then at a decade, it was 2002, and the WHI trial came out, and everyone freaked out. So they took them off of it, but they followed them for 5 more years to see what happened. And all those women were early 50s when they started. Half of them were smokers because it was Denmark. So these were not particularly healthy people. And the women who went on bioidentical oral estradiol had a 40% lower mortality over that decade than the other women. There is nothing on this earth that will lower a woman's death rate by 40% during that decade beyond estradiol. And then when they took them off of it during the next 6 years, the women who had been on the estradiol, their death rate slowly rose towards that of the placebo women. So they should have left them on it for more than 10 years. And that was 2 milligrams a day. That's a high dose. I rarely use that much. But what can I tell you? I mean, that's it. You're trying to, you're talking about saving women's lives. Like, every woman should be on estradiol at menopause, in my opinion.
Okay.
But,
all right.
But
okay. Well,
I would love to use progesterone pellets, but I got to use enough to, keep their. And I don't use estradiol pellets too much because of exactly the reasons you opened with about, bleeding. It's tough to know that. So I end up using testosterone pellets in low doses sometimes, mainly because the 5-alpha reductase enzyme lives in your skin. So if you give them cream, they're rubbing it right through that enzyme and they get a lot more DHT. So those women, I use testosterone pellets. And then I use oral estradiol and oral or cream for progesterone. But I would love to use less oral progesterone if I could, because a lot of them get bloating,
Yeah.
So,
yeah,
I mean,
I'm not going to argue the estrogen. That's a whole different philosophy. I know there's a philosophy about that. Yeah. I believe that, and I won't say I believe that balance is the key. And if the estrogen is low and the progesterone is low and it's in balance, then you're going to be fine. And then now, okay, we won't talk about that. But anyway, progesterone, 100 to 200 milligrams. And it's really the more active the person is. The studies show that the more active person is, the higher the dose is going to be, because the quicker they're going to use it up. So anywhere from 100 to 300 is fine. And again, I'm not giving them extra estrogen, so I'm not as worried about their endometrium, So,
fair enough.
So you would.
I would love to do this in younger women too, progesterone pellets, for the reasons you mentioned. That's cool.
Yeah, because then, because it's just like a cream or whatever. You put it in a younger person, and she's still having her menstrual cycle. So I'm not giving her enough to make her stop having menstrual cycles. And I don't know if progesterone at a higher dose would actually be a birth control. I'm not ready to do that experiment, but it is a possibility. But for her, she's still having menstrual cycles, and her bleeding is more regular and whatever. So
that's what pharmacy you get it from, or where you get the product?
It's Belmar Pharmacy. They have a new it's Belmar out in Colorado.
Cool.
Yeah. So
Eldred, if you're using say 10 milligrams of cream a day for a postmenopausal woman, does that usually equals 100 milligrams oral? So you put in 100 milligram pellet? 100,
yeah. And I'm going to tell you, I started off putting in 100, and I really think that probably 150 should probably be the lowest dose. So I mean, you're not really it's not going to overdose them, and it's more likely they're going to be symptom free for 3 months.
And that would be 3 pellets.
That would, 100, it'd be 3 pellets. Yeah. So it would cost you, what, 30, whatever. What's 4 times 14?
42.
$42. And then the kit is about $20.
Does the kit come from Belmar too?
No. You know what? I'll give you some information. Gosh, I can't think of the name right now. If you look up, we could probably look it up.
Do they fit through like a 3 millimeter trocar?
Mm-hmm. It's, what is it, 3.5 millimeter? Yeah. You know, you have to use the bigger one for men,
Okay.
but there's a smaller one. It's 3. I think the men is 5.4, but no, it's small. The pellets are, like the top of a pen. It's like what you're probably using with testosterone pellets. So let me see how many people. Any other? Because some people aren't on video. Let me try and. This is a newfangled thing I have here. I'm trying to make sure I know how to. Yeah, here we go. So does anybody else have any questions? Trying to see how you can raise your hand.
Yeah, I have a question, Eldred.
Okay.
So with your, if you were to start somebody on the progesterone cream, do you generally dose then about what, 10 or 12 a day, or where do you go with, like, you're starting them?
But I go by how big of a gap we have between estrogen and progesterone. So if their estrogen is, if their estrogen is really high and their progesterone is really low, usually my range is 10 to 30 milligrams a day. And they take a half a ml a day. So if their estrogen is really high and their progesterone is really low, I'm going to lean more toward the 30. If their estrogen is not that high and their progesterone, there's not that big of a gap that I'm trying to fill, then I'm going to go more toward 10 or 20 milligrams a day. And then usually I'll get them, if they're premenopausal, they do it from day 12 through 26. If they're postmenopausal, they do it for 3 weeks out of the month and take 1 week off. And then I'll usually test them when they're not on the progesterone because I want to make sure that the progesterone is not building up in their tissue. So
I've been,
yeah, go ahead.
Another question on that is that I'm generally not giving women estrogen if they're postmenopausal unless they're pretty tiny, like the big ones don't need it. But I'm finding that if I get like 15 milligrams or above, that they seem to almost be progesterone dominant, and then I get a lot of complaints about hot flashes. And I don't know if you have any insight on that.
Just for 15 milligrams?
I'm finding that, like, I've had several patients where I went just progesterone with a tiny amount of testosterone, maybe 0.4, but they were getting hot flashes at 15 milligrams. And so I've been kind of scaling people back to 10, and I don't know what your thoughts are on that.
Yeah, that's a low dose for them to be, that's a low dose. Yeah. Now, what you can do is, if they're postmenopausal, if you do their salivary estradiol and they're in the low range, sometimes, maybe they need a little estrogen with that progesterone.
That's what I'm wondering because.
Yeah,
I have a patient I just talked to today, and she's on. I put her on 15 and 0.4, and she did great the first month, but she's 49, so she's still menstruating. So she stopped it for the period, and then had hot flashes after that. So she's feeling better, but.
Yeah, she stopped it for the period and then had hot flashes. Mm-hmm. Sometimes with those people who are perimenopausal, I will put them on oral progesterone every day. Because what that does is, if they have a cycle where they're making enough progesterone, then it's not enough to put them over the top. Okay? And then if they don't have a cycle where they make enough progesterone, it's just enough to keep them from hitting rock bottom. You understand what I'm saying? So it kind of gives them a floor. If they have a ovulatory cycle and they make a bunch of progesterone, then that floor is not enough to make them progesterone dominant. Sometimes if they have a cream and then they have a cycle where it's actually ovulatory, now they have too much, then they have a period and it goes down. So that may be what's going on with her, especially if she's still menstruating. So yeah, perimenopausal women, I will use an oral and just tell them to take it every day, and so they don't get that fall.
Do you ever just have them take it the whole cycle, and does it inhibit the periods eventually?
Oral or cream?
Cream.
sometimes what I'll do if on their cycle is tell them to cut the dose in half.
Okay.
Instead of stopping it, cut the dose in half. So again, they don't have a big drop.
Okay.
So you could do that.
Yeah.
All right.
Thanks.
So I think I don't. This thing doesn't have a little raise your hand. So what you have to do is unmute yourself and just jump in here if you got a question. I may kind of go through here. Dr. Smith, I beg your pardon?
I think there is a raise your hand. If you click on participants at the bottom,
Okay.
I'm not sure
I
now.
see participant. Oh yeah, Josh just raised his hand.
I'm lowering it.
Raise hand. Yeah.
Yeah, it did come up. Okay, great. I'm glad that maybe you guys see it and I don't. But Josh, how did you find out about this webinar?
I got an email, but I'm not sure who sent that.
Yeah, I sent it. Tell me where are you practicing?
Like my background. You know, I've been affiliated with AMMG in the past, and I know at least once I heard you speak at AMMG. This was a few years ago.
Yeah.
I work with Erica Schwartz in Manhattan. I don't know if you've heard of her, but she has a hormone practice in Manhattan for many years. I joined her about 3 years ago. So
okay.
I'm not sure what email list I wound up on, but
okay, yeah. Okay, well, good. Well, I'm glad to have you, and again, that's that debate about saliva and blood and estradiol, and I mean that's a long-standing debate. And,
I'm sure, yeah.
and so
and I admit I don't know much about saliva testing. I haven't learned much about it.
Yeah. So, but with I'm glad. I think I'm trying to put progesterone pellets out there on the map to say, hey, look, I think everybody agrees that progesterone is important in women. And if you can do it where you can decrease your worry about compliance and, like you said, giving estrogen and hoping they're going to take progesterone and worrying about their endometrium, whatever philosophy you have, this is something that I think people need to know about. And I don't think a lot of people do know about it. And the people who are talking about it the most are really just pushing estrogen and testosterone. And, I just couldn't settle for that. So even if you're in that ilk, I think this is something you should add. If you're not of that ilk, this gives you an opportunity to do what you think is best, and it gives you another option and gives the patient another option. So I wanted to kind of put that out there, and if you're interested, if you're already doing this, you can just add it to your armamentarium. But people who are kind of new to this and want to add pellets because it can be a revenue stream, it can increase compliance. We are having a workshop on. Try and find it here.
I think it was April 21, April 22.
Yeah, thank you. Yeah, and I'll send out an itinerary for that, and we'd love to have you. And we'll talk about the whole philosophy of hormones, and I'll tell you. Some people I know that you did this, the study about the oral estradiol, but a lot of people have problems with oral estradiol because of it making it converting into estrogens and breast cancer. So that's a whole controversy. So there's a lot of controversy out there about all of this stuff, and you do the best you can. You try and monitor people the best you can, and do what you think is right. So I'm not going to fault anybody for doing what they think is best for that patient. Let me try and figure out how to get back to telling you, man. Share. Okay, Sarah Starr raised her hand. I'm trying to get back to.
Yeah, Eldred, about that patient, the young one.
Yeah.
With the progesterone pellets. What do you advise her about conception or, need a need for birth control, or because I'm assuming this is probably going to suppress ovulation during the time she has it.
Well, that's a good question, and I don't know. Now, let me tell you, this girl, she was brought to me by her mother because she was just she was a problem child. So she got pregnant, like when she was 15 or 16, when she was having all of her mental problems, and so they put an IUD in her. So I didn't have to worry about that. But I would think that if I'm using progesterone like that, I would still say that they need some type of birth control. And even if they're on an oral birth control pill, I would still think that the fact that they have progesterone is a good thing. Now, you're talking about if she was trying to conceive. Now, again, I haven't gone that far because I haven't used them. That's a question we would have to try and figure out. Can I give her enough?
Or what if a woman wanted that as birth control instead of Norplant? It's a lot healthier.
That's the age-old question. Whenever I talk about this, people say, well, you should be able to use progesterone. You should be able to use progesterone as a birth control method. But, the problem is, how much do you use? Somebody would have to do a study to see, how much would you use? How effective is it? And nobody's going to do the study because no one can patent it.
Yeah, and would 300 be enough?
Yeah, and that's what
probably enough to make you feel better, but it may not be enough to keep you from ovulating.
Right. So that's something that would have to be other time, and talk about. You share with me your studies, and I'll show you my philosophy. You don't know much about salivary testing.
That's true.
But it's something that you may want. This is what I would tell you. If you're using oral estrogen, okay, and you're using oral progesterone, you can get elevations in the serum level. Okay, if you're doing things orally, you can get, because it goes through the liver. It will have it will have water soluble metabolites that will show up in the water soluble serum. But when you're using hormones transdermally, you're not going to readily see it in the serum because it's going to go in the tissue first. And the only way you're going to see it in the serum is if the tissue is saturated, and now it doesn't have any room in the fat-soluble tissue. Now it goes back into the water-soluble space where it really does not want to be. Okay? So if you're using oral estrogen, you may be able to get a serum level that is representative of what's going on because the liver is allowing fat-soluble metabolites. So there probably is some relation between how much is going through the liver and how much is in the serum. But once you go transdermal, it's not in the blood long enough for you to see it. The saliva is giving you a tissue level, and I can show you studies about it. It's a tissue level of it, so you can see how much is actually in the tissue that you don't see in the serum. All right. So but if you go to transdermal estrogen, it's going to be harder and harder for you to see it in the serum. And that's also what I'm concerned about in the pellet because it doesn't go through the liver first. So it's not making those water-soluble metabolites that allow you to gauge. So you can think of, well, based on how much estrogen I'm giving, how much metabolite is going to make, and I've got a range that I can deal with. Okay?
Right.
But the other side of oral estrogen that you'll hear people talk about is that its propensity to make estrone, which can make quinones. So a lot of people are anti-oral estrogen. You probably heard that debate.
For sure.
Okay. So it's all, you've got all of these different sides of this to look at. So that's it. Like you said, I mean, there's nothing wrong with it.
I would love to, I would love to find out a little bit more about saliva testing. Can I email you just to kind of?
And let me tell you another thing, what I'm developing. And Dr. Starr and Dr. Zimmerman, they've seen it. I'm developing an online course to just kind of get my philosophy. It's not my philosophy. It's the GYN textbook philosophy. Okay. Now they don't talk about salivary testing, but I have an online course, and what I'll do is email me, and I'm going to send it to you and let you take a look at it, and then let's have another discussion about it. I'm always open to discussion. I feel like a lot of people out there are, just because you yell the loudest doesn't mean you're always right. Okay? And some of it that you're yelling about is probably correct, but then, just like I'm saying, hey, I'm willing to learn from you, and you learn from me. We're all trying to do the best for our patients.
For sure.
And if you do something different from me, it's not that you're a bad guy or I'm wrong or you're wrong. This is what you've done. You've worked out a method. I'm just saying, hey, there may be some methods and some people that don't fit that model. You might go to this model and say,
for sure.
Yeah, hey, this tells me the answer. So anyway,
sure.
So yeah, email me. I'll send you that. Dr. Zimmerman has helped me to create it. So it's a way for me to kind of get some information out there where you don't have to show up somewhere, and I don't have to show up somewhere. So,
okay.
So
Yeah,
if you're interested in that, beg your pardon?
I wish we had my first saliva test to show him.
Yeah, I know. Yeah, I know.
I started on high dose creams when I started doing this and came to Eldred's lecture, and he had said, you've got to check your saliva. Once you've checked saliva and you see a patient who's been on high doses and the astronomical levels, it'll change the way you view it forever.
Yeah. And again, now you're not using
I learned it
cream.
myself.
Yeah.
No, I do. I use both. I use both. I use a little bit of everything. I've used pellets. I've used creams. I've used oral.
Yeah.
I have patients that obviously don't want to be on oral. My main thing is that listen, I'm a data hound. I like to follow the stuff that's in the published papers that, over the years have shown the best results. And so that's why I'm not quote unquote afraid to use oral, because breast cancer risk did not go up except in patients that use, synthetic progestins.
Yeah, the progestin, I agree. The progestin is the bad actor. Okay.
But we'll see. I'm happy to listen. I'm happy to learn new stuff. Maybe I'll change my.
And you know what? Again, you may not deviate, all the way, or something you might say. But hey, this is really confusing to me. It's not making any sense. What the heck? Let me see what the saliva shows. Maybe it'll show me something that is not.
Definitely. There are definitely patients where I have, trouble. Progesterone's my most problematic hormone. There are definitely patients where they're bloated or whatever. I'd love to find any time, if I can find a new trick to look at and see just things. I'm happy to learn.
All right, great. So send me an email. I'll send you that little online course that I have. It doesn't take that long, but it's just and then let's get together. We'll talk again.
Cool.
All right.
All right.
Any other questions, anybody?
Thanks.
Is the workshop practical?
Yes. We're going to show you how to do it. I'm working on getting some models to come in. I may even, if I do one, is tape it and take one beforehand, take one during, and then we're going to go over. I want to talk about hormones, but I also want to talk about other things that may be involved. We're going to talk about progesterone. We can talk about all of that, but then also, talk about heart rate variability and talking about heart disease, digital pulse analysis, what that does. So, this is one thing that we want to do. But again, a lot of times I have to go over we have to start from scratch with some people and to say, hey, this is how I think about it. How do you think about it? But, the practical part of it, if you ever put in Norplan, the practical part really isn't that hard. You make an incision, you put it in. It's really not that hard. We can talk about dosing and monitoring. What other things can we do for patients? So we'll look at it. We'll look at it in a holistic type way. But it will be practical. You should be able to go back and do it, Monday morning, no problem. It's not brain surgery. You're going to be working in the buttocks where there's a lot of fat tissue, and most people You're not going to be near the sciatic nerve. You're not going to do any of that stuff. It's very low complications with pellets. That's why it's good, and that's why a lot of people are doing it, because it's easy, but it's also bad because everybody's doing it and they're not really understanding hormones. Because, yeah, sometimes it's too easy. So, hold on, let me see if some chat here. I would love to get in touch with you and have this conversation. Okay, I have to go. All right. All right. How about weight gain issues? Yeah, I don't see weight gain with progesterone. I mean, you see weight gain when you deal with synthetic progestins, but progesterone usually doesn't cause weight gain. Now, if you overdose them, they can get bloating. It can slow down peristalsis, but usually you don't get weight gain. All right. All right. Is everybody okay? It's an hour. Dr. Salter?
Yes.
Yeah, did you, I see your name pop up here. Did you have something you wanted to say?
Well, I asked about whether the workshop was practical or not.
Okay.
Yes.
Yeah, it's definitely going to be practical. We always say that, hey, if you can't go home and do something that's going to help your patients, then it's not worth, it's not worth coming. So, and what I may do also is send out a coupon for anybody who joined the webinar. I have to talk to the boss lady to see what we can do, but we'll give out some kind of coupon. And
Okay.
also, we have this recorded, and I'll send out the recording also. All right?
Okay, sounds good.
All right, so it's 8:57. We've been on here for an hour, and I hope to start doing more of these. I'm going to have this online course, hormone replacement by the book, the stress connection, all of those. And if you have colleagues who would be interested, please email it to them. If you've already heard all this stuff, email it to them. Let them know that this is available. I would really appreciate that. All right, so I'm going to end the meeting, you guys. It's so nice to see everyone. And we'll talk with you guys soon.
Okay, thank you very much.
All right, bye.